Hi everybody, today we're going to be doing a video about hematocrit. It's something that people often talk about in relation to their testosterone treatment for their testosterone deficiency, and it's something that raises concerns, and you'll see all sorts of different conversations about management of hematocrit. And Felix and I today are hoping to go through when it's an issue, if it's an issue, and what, if anything, do we need to do about it. Is that all right, Felix?
Yeah, no, that sounds great. Yeah. So, yeah, no, we've been talking about this a bit quite recently, haven't we? So you see it sort of going in peaks and troughs in popularity on the online forums and groups on social media and things, and then videos and things about it on YouTube, and it can get people quite worried. And I think the reason for that is because of a long-held misunderstanding in the medical community as well. Like there's plenty of healthcare professionals out there that mistakenly think that elevated hematocrit is something that needs to be managed on TRT. And we'll probably delve into why that is.
Yeah, exactly. And I think, it's really quite common, particularly new patients that are coming into the clinic, that might be reaching out to other forums. And I do understand, because sometimes testosterone deficiency has been missed or not treated for so long that patients have really had to become their own experts. And actually, they might be getting information from people who are speaking with great confidence about, the dangers of elevated hematocrit in people who are taking testosterone. And I think that's really where, when you get these concerns coming in after their first or maybe second blood tests, talking and just sort of trying to help people understand the risks, or, if there are risks, and what, if anything, we need to do about it. So not uncommonly, I will get concerned patients saying, I've been on testosterone with another clinic. I'm concerned about this. And sometimes they've even been told by clinicians that they need to start considering either significant reduction, or coming off testosterone, changing testosterone form, and sometimes venesection, or therapeutic venesection, which is sort of offloading some blood. And these are the patients that we need to get a little bit more information from. So generally speaking, I start by finding out a little bit more about the patient history and finding out whether or not they've got any risk factors for coagulopathy, and that can look at, so that means that any more sort of clotting disorders. So I think there's an association where people sort of believe that having an elevated hematocrit might put you at risk of heart attack, clotting events, so pulmonary embolism, so clots in the lungs, or clots in the blood vessels in the legs. And that's what people are concerned about. And there's a belief that if you essentially bloodlet, which sounds somewhat Victorian, that this will reduce those risk factors, when actually you could be doing a little bit more harm than good.
Yeah, for sure. I mean, it's a really common picture that you see, and going back to what I said at the beginning, I think this is all born from a misinterpretation or a misunderstanding, or perhaps just potentially being taught by someone throughout your healthcare career that also misunderstood it, and it's completely innocent. They didn't have someone correcting them, and I think that's where we need to start looking at the difference between primary and secondary erythrocytosis, with erythrocytosis being too many blood cells. So going back to the origin story of this, I think is primary erythrocytosis, which is something most widely known cause of that is polycythemia vera, which is as the name suggests, is a primary disorder of the blood, and that is actually a type of blood malignancy, where it's a genetic polymorphism in something called the JAK2 gene, and it's where you actually produce too many red blood cells. But that's not really, whilst that is part of the issue, this is quite misunderstood as well by a lot of people when you speak to them. It's actually more platelet dysfunction that causes the issue there. And yes, they do actually benefit from therapeutic venesection or bloodletting, letting some of that excess or thick blood out. Now, this then also is accompanied, and this is where it gets confusing for people, by an elevated hematocrit. Now, hematocrit is simply the measure of the thickness of your blood. It's a ratio of the solid components of your blood to the liquid, which is plasma, and then the other one's obviously platelets and different types of blood cells. Now, yeah, that's a very simple way of putting it, by the way. And now this is where people see that elevated hematocrit in polycythemia vera, and they associate that with blood that's too thick, raising blood pressure, and we need to get some out. Now, they then port that belief over to any type of erythrocytosis. Now, this is where TRT comes in. So you know, very commonly, and in fact, most of the time, you will see a mild secondary erythrocytosis by being on exogenous testosterone. And it's that belief ported from polycythemia vera to TRT that people conflate the two and think that they equal the same when they do not.
Yeah. But in the absence of that platelet dysfunction, it just doesn't carry the same risk. And I think also, interestingly to say as well, like some of the symptoms of testosterone deficiency in the first place are actually stemming for some people from an anemia. And actually, it's really quite common in men to have low-grade anemia prior to starting their TRT for their testosterone deficiency. And actually, you know, this is one of the positive benefits that you'll get. You know, you'll get better oxygen carrying capacity, and actually, this is a good thing. So actually, then taking that blood that you know, your body's gone out of its way to provide for you, secondary to having more treatment, is actually really, really counterintuitive and can have a negative impact.
Yeah, and it carries other risks. This you know, people that push therapeutic venesection then push men on TRT into iron deficiency, because the one thing that's not really known or talked about too much, other than in circles of people that work in this field that have a good understanding of it, is that when we take exogenous testosterone, we downregulate other things. Now, one of those things is hepcidin. Hepcidin is part of is a hormone that's responsible for how we store iron. So you have two types of iron. You've got ferritin, which is generally speaking our stored iron, and then you have ferrous iron, which is what's in our bloodstream. Now, unfortunately, when there's no getting around this, exogenous testosterone use, even at therapeutic levels, will slightly downregulate hepcidin production. Now, when you do that, you don't store iron very well, so your ferritin can be lowered. Now, if you take the situation where you have a lowered iron storage capacity and then let some blood out, you obviously lose your circulating iron in your bloodstream. So your body, what does it do? It goes to your stored iron, your ferritin, which is usually stored in tissues and the liver, and it pulls it out and it puts it into the bloodstream, because we need iron in order to carry oxygen. And now when you do that and you then aren't able to replenish it, you get stuck in this horrible cycle of ferritin deficiency. And that's what happens if you tell a man on TRT that they should let blood. You send them into ferritin deficiency anemia, and trying to get that back up is actually quite difficult. So trying to keep your ferritin levels where they are on TRT is the goal, really, because you don't want to be losing that, because it is harder for us to produce that when we're on TRT.
And the weird thing about it all is as well that the symptoms that you're going to get from that are also tiredness, lethargy, sort of general malaise. Exactly. All the things you're trying to get away from in the first place with your testosterone deficiency.
And that's it. You know, and there's so much evidence. Like, so for example, these are just a few studies here. So you'll see this come up on the screen in a second. I'll just add that to the stage. So just here we've got a study that looked at, it's called the reevaluation of hematocrit as a determinant of thrombotic risk in erythrocytosis. Now, the reason I put this study on is because this is actually very good at determining the risks associated between the two types of erythrocytosis, and that's primary and secondary. So if you haven't read it and you want a better understanding of what primary of erythrocytosis is and secondary is, and therefore the associated risk of thrombotic events, this is a very good paper to look at, because it clearly delineates between primary and secondary erythrocytosis and their risk strategy, their risk stratification. And it very much concludes that if you have secondary erythrocytosis, there is no association with increased risk of thromboembolic events. So that's a paper I think that is, you know, a pretty seminal one for people to read, and it's from 2019, so it's fairly recent. And then we've also got a couple of other papers that I just wanted to throw in the mix that actually are more targeted at our audience, so our guys on TRT. So this one in particular, I'll just put that on there. There we go. You'll see, and you'll see the title is Association Between the Use of Exogenous Testosterone Therapy and Risk of Venous Thrombotic Events Amongst Exogenous Testosterone Treated and Untreated Men with Hypogonadism. Now, you cannot get more a targeted audience to the people that we need to be thinking about, because it's all very well with the previous paper talking about these two conditions, but we want to know how that applies to our patient population. And this paper did it exactly. Now, this is back from 2016, so probably you could argue it's a little bit dated, but the conclusions nonetheless were very good in terms of allaying our concerns about a high hematocrit being an issue in TRT. And by as you can see on the screen there, no significant association was found between exogenous testosterone therapy and incidence of idiopathic or overall venous thrombotic events in men with hypogonadism. So, you can't really get much sort of better than that, or you would think you wouldn't, but then you want to talk about powers in numbers. And that brings me on to this final paper, which was a very, very large retrospective cohort study, which looked at, I'll just pop that on the screen for you now. There it is, testosterone replacement therapy and the risk of venous thromboembolism. And this was a systematic review and meta-analysis of RCTs. So when you look at the patient population they looked at, they had just under 3,000 men on testosterone to look at their associations with thrombotic events and being on therapy. And then they had a control population of over 11,000. So, and the conclusions came out as the systematic review suggests that TRT is not associated with an increased risk of VTE. So, it's something that I think there's, that's just 3 papers. Like if you look back and do an actual search, there's about 30 years worth of this data.
And I think one of the things I find frustrating is that these are such significant papers, and they've been out long enough, as you quite rightly pointed out, with decent sized population and decent controls. Yeah. But what I find really frustrating and really sad is that patients who often, like I said, have been misdiagnosed or undertreated or not treated for so long, having to become their own experts, and then quite understandably getting quite concerned when another medical professional sometimes, or somebody else who's been interested in testosterone deficiency and the management of, comes up with these concerns about hematocrit. And you do understand that actually, somebody who could have been really quite normotensive before gets quite concerned and blood pressure goes up, and so I think for me that really big differentiation is that platelet dysfunction that we talk about, and we know being the difference, the fundamental difference between elevated hematocrit being problematic, but it's just so very different from the causes of elevated hematocrit in patient population with who are on testosterone replacement therapy. And I also think the other thing is that the elevation, the increase that you see in people who are on therapeutic amounts of testosterone and who have therapeutic levels of testosterone, so i.e. not super physiological, and the risk factor, potential cardiovascular risk factors, often in patients being managed therapeutically for testosterone replacement therapy, I think are actually, as we've discussed and as have been highlighted here from those, relatively low. We still need to manage cardiovascular risk in these patients, but not necessarily secondary to their testosterone replacement therapy, just because they need monitoring, as does the rest of the population, but not secondary to that testosterone replacement therapy.
I mean that's been put to bed a long time ago, in that all-cause mortality for deleterious cardiovascular events is reduced from the baseline that they were at. When you're hypogonadal, you have an increased risk of deleterious cardiovascular events, and when you are normalized on replacement therapy, not super physiological, your risk reduces. That's something that's been, massive studies have looked at that with, tens of thousands of patients in cohort studies. So, this sort of antiquated understanding or misunderstanding that TRT can cause you to have high blood pressure because it elevates your hematocrit is completely unfounded, and the evidence is there to suggest that.
But I think this also goes back to, you get a lot of people sort of wanting real black or white. So do I not have a risk, have any risk for cardiovascular risk now I'm on TRT? No, that's not the case.
No.
You still lifestyle stuff alongside it. Testosterone is not everything. You still need to manage your body composition and your body weight. You still need to obviously be managing a good appropriate diet and nutrients. Alcohol is another really big one. Other drugs, supplements, medications. It's a part of the puzzle for people who've had testosterone deficiency. But it is.
I think that's key, isn't it? Like, I mean, it's all about management of expectations on TRT. And one thing I often say to patients is that the TRT is probably 20% of their problem. The other 80% is their lifestyle, diet, and exercise. Because if you don't have those in check, TRT isn't magic. It's not going to reduce your risk from those other things being out of whack. It's the final piece of a jigsaw.
Yeah, absolutely. And I think also mindset, because testosterone deficiency has such an impact on mood. And, if somebody's been deficient for 10 years and they've lived in a certain way, they've developed certain brain patterning, certain decision-making processing, then actually when, you get people, I'll get an email every so often, sort of 4 to 6 weeks in saying, still feel exactly the same. And it's that developing that awareness and that understanding that actually there's a lot of work that needs to go in behind. Yes, the testosterone started to have its process and started to have an impact on your physiology, but actually it's also, and this is where I get a little bit pissy about the whole sort of functional side of things, and trying to get people to sort of develop that self-awareness, partly sometimes through journaling. Some people will be reaching out, YouTube videos, it might be reading and things like that. But
but it's also, I think, on that note, it's important to mention that there needs to be balance, because you can go down a rabbit hole of being too aware and then focusing far too intensely on things, and that can increase anxiety, which then also ends up leading to an overall state of not optimal psychological well-being, because you focus too much on, like, I did this with my dose and then this happened, it must be that, and having the association drawn. It's about just taking a balanced approach to everything, because everything has its place and its function, and only when they're at the right levels with each other will it mesh together for you to be able to feel normal. Because there's a lot of I get a little bit not defensive. I get a little bit sort of this word optimizing. It frustrates me a little bit, because yes, you want to optimize your levels in terms of serum testosterone, but focusing on a number and then equating that to you feeling a certain feeling is no way to be living. Right? It's forget about the numbers and concentrate more on how you feel, and try not to associate negative feelings with numbers, because that's not how it works. Like, when you weren't hypergonadal, you never once thought about measuring your testosterone, and you felt good some days and bad some other days, and you never thought it was to do with your hormones. You just thought it was life. And that's what you need to be like on TRT, is just forget you're on TRT and crack on with life. And there's going to be good days, there's going to be bad days. And as long as there's a balance in that, then that's called normal living. It's
exactly. Yeah. And I think, to be honest with you, I think the reason why so many patients in this population end up having those conversations, and you see on these forums going, what's a good dose for, or what do your numbers look like when you feel best? And you kind of think, it kind of makes you cringe. But at the same time, like I just said, these guys might have taken years to get to that spot where they're speaking to a clinician who they feel understands their need. And actually, they're just trying to understand things as best they can. But like you say, it's almost nice sometimes for the patient not to have seen their numbers. They're like, so how are you doing? How are things? And then you're also finding out about, how's relationships, how's home, how's work, how's you, and finding out all those bits first before you sort of almost unveil the numbers and say, right, okay, so this is where you are.
I've had that many a times in the past. So the previous clinic that I worked at, I wouldn't release the blood results until they completed their pre-appointment questionnaire, asking them how they were feeling. And you wouldn't believe the amount of paradox you would see in that. They'd be like, I feel great, absolutely brilliant. And their numbers were terrible. Like, so it's, and vice versa. They'd be like, oh, I'm not feeling great. And they had absolutely cracking numbers. So there is no real relationship between numbers. So shooting for a target number in terms of total or free testosterone, in my opinion, is a bit moot, because and that was demonstrated by them filling in these questionnaires before knowing what their bloods were. Like, so because you would get the complete polar opposite of things on many, many occasions. So
That's
it is
really
vastly
interesting,
multifactorial.
Yeah. No, that's fascinating. And I think, like a lot of our colleagues are sort of regularly mentioning just, all the Billy basics of nutrition, of sleep, and of making sure that you're living according to your own values and feeling comfortable with the lifestyle that you're living and everything is so important.
I mean, that's going back to hematocrit, like sleep apnea. That's a silent killer. Like, that is probably the number one cause of people having an elevated hematocrit. You see patients on TRT with an elevated hematocrit, and you tell them not to worry, it's not associated. Just like we've discussed, they start on CPAP, and you watch it just go down. Like, and that was the cause all along.
Yeah, absolutely. And I think actually there's a link on the website for home sleep apnea test kits that literally will be delivered to you. I think they're less than £200. There's a small discount code on the website as well. So, if there is something that you think that you're impacted by, it's worth just checking out at edenclinic.co.uk, Eden Clinic for Men, .co.uk. And you can actually book in for one of those tests if you think that's something that impacts you. So, it is definitely, sleep apnea is absolutely worth investigating and finding out. It's quite tricky to get tests for in the NHS, but those
it is. They have a remarkably high threshold, and so on the NHS you will only get the opportunity for a trial of CPAP if you breach the moderate to severe score for on your AHI, which is a sort of index of how they measure whether your oxygen levels are going below a certain level, your snoring, your tracheal collapse, things like that.
And it's quality of life is pretty impressive.
Yeah, it's these are guys that and one thing to clear up as well, a lot of people associate obstructive sleep apnea with morbidly obese people. And yes, it's seen higher, but you can have a completely normal build and still have a high AHI. So, and require CPAP. And then when you try it and you get used to it, because it's one of those things that does take getting used to. But once you try it and get used to it, your sleep quality improves, and you'll see your deep sleep go up and your light sleep reduce. Whereas before it'll be the complete opposite, massive amounts of light sleep and hardly any deep, and you don't feel recovered. But it's a huge change for people when they finally get on the right kind of treatment and get quality sleep.
Brain fog that people talk about really lifting almost like a cloud once they get onto CPAP. Obviously, like you say, I think the machines can take a little bit of time to get used to, but it's usually only sort of a week or two before you're sort of back in, so it might be a little bit bumpy initially, but so
I believe, my advice to anyone with CPAP, if they are starting out with it, is just stick with it, keep going, because eventually you get used to it, and it will make such a huge difference.
No, absolutely. Awesome. So, I suppose essentially all in all, Felix, thanks for sharing those papers. I think they're really useful. And for anybody needing any reassurance or, having any questions or concerns, please do drop them below. But, understanding other people's misunderstanding, so to speak, of elevated hematocrit in patients on TRT can sometimes be reassuring, because I think sometimes when you get bounced around from clinician to clinician or somebody else who's had an experience in treatment of testosterone deficiency, you can sometimes get a bit like, well, who's telling the truth here? But actually, I think those papers are actually really, really robust, good cohort sizes with good study designs. And hopefully you should be able to get some reassurance from that. But if not, if you've got any questions for either of us, please do drop them below. We'd love to hear them. And we look forward to seeing you on the next video.
Yeah, make sure you like and subscribe, guys.